Hello and welcome back to ClinMed Compass. I am Dr. Emorican, and today we'll be exploring key clinical facts on pneumothorax. I'm going to break it down in a way that's clear, structured, and clinically relevant. Perfect for medical students, postgraduate residents, and other health professionals. Grab your pen and paper and let's dive in. Pneumothorax refers to the presence of air in the pleural space. It may result in partial or complete lung collapse. It can be spontaneous, traumatic, and iatrogenic. Classification of pneumothorax. We'll start with the etiological classification. One is spontaneous pneumothorax, which is subdivided into primary spontaneous and secondary spontaneous pneumothorax. Primary spontaneous pneumothorax occurs in otherwise healthy individuals without evidence of lung disease. It is typically caused by rupture of small pleural bulbs, which causes air to escape from the lungs into the pleural space. For primary spontaneous pneumothorax, there is a very strong male predominance, about ratio 6:1. The risk factors for primary spontaneous pneumothorax include a tall, thin habitus, the male gender, age less than 40 years, smoking history, which increases the risk by 20-fold, a family history of primary spontaneous pneumothorax, apical subpleural blebs or bullae, and connective tissue disease like Marfan's syndrome. Now we'll take a look at the secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax occurs in patients with pre-existing lung disease. It is associated with high morbidity and mortality, and common associations include chronic obstructive lung disease, bronchial asthma, cystic fibrosis, pulmonary fibrosis, pneumonia, lung abscess, tuberculosis, lung cancer, connective tissue disease like Marfan syndrome, Ehlers-Danlos syndrome. In fact, all forms of fibrotic and cystic lung disease could actually be associated with secondary spontaneous pneumothorax. 2 is the traumatic pneumothorax. Trauma accounts for 30 to 50% of pneumothorax cases in trauma settings. Traumatic pneumothorax could be non-iatrogenic and iatrogenic. For the non-iatrogenic, it may result from blunt or penetrating chest injuries, things like rib fractures, stab wounds, gunshot injuries, or even barrel trauma in divers. For the iatrogenic traumatic pneumothorax, this type results from medical procedures such as central line insertion, thoracocentesis, mechanical ventilation, lung biopsy. It is important to always be vigilant during these procedures. Now we'll look at the clinical classification of pneumothorax, which is based on airflow. First is the closed pneumothorax. In closed pneumothorax, air leaks into the pleural space via a lung breach, but the communication seals off. Hence, the pleural pressure remains negative, so spontaneous re-expansion of the lung is possible. Second is open pneumothorax. Open pneumothorax involves an external chest wall defect with ongoing air leakage. So this persistent communication between the airway and the pleural space results in an ongoing air leakage into the pleural space. An example is in bronchopleural fistula, and this may lead to infection. Third, we have the simple pneumothorax. A simple pneumothorax is one without hemodynamic compromise or mediastinal shifts. Then we have tension pneumothorax, which is a life-threatening medical emergency. In tension pneumothorax, we have what looks like a one-way valve effect. Air enters during inspiration but cannot escape. This causes progressive air trapping, which eventually raises the intrapleural pressure, compressing mediastinal structures. The rising intrapleural pressure results in mediastinal shifts, compression of the opposite lung, impaired venous return, and eventually cardiovascular collapse. This is an illustration of the various forms of pneumothorax. The first is the closed pneumothorax, where the communication seals off after the rupture of the lung, maintaining the negative intrapleural pressure. The second is the open type of pneumothorax, in which there is a persistent communication between the airway and the pleural space, as you can see, as in the case of bronchopleural fistula. This is the tension pneumothorax, which acts like a one-way valve. Air enters the pleural space and gets trapped and cannot what? Exit. So what happens? You have progressive air trapping, which eventually raises the intrapleural pressure and causing compression of the mediastinal structures to the opposite side. Pathophysiology. Under normal conditions, the pleural pressure remains negative. This helps to keep the lungs always inflated. However, in cases like pneumothorax, there is disruption of this balance by allowing air into the pleural space. This can occur as a result of rupture of the subpleural blebs or bullae, disruption of the pleura as in trauma, air leaks from the tracheobronchial tree as in ruptured bronchus. So this entry of air into the pleural space neutralizes the negative intrapleural pressure, thereby resulting in lung collapse. In tension pneumothorax, as earlier stated, the one-way valve mechanism allows air to enter during inspiration, but not exit during expiration. This causes rising intrapleural pressure, which can lead to ipsilateral lung collapse, contralateral mediastinal shift, compression of the great vessels, impaired venous return, which leads to decreased cardiac output, and eventually hypotension and shock. The symptoms of pneumothorax can vary by size of the pneumothorax. Small pneumothorax may be asymptomatic. However, symptoms include sudden, sharp unilateral pleuritic chest pain, dyspnea, and occasionally cough. Symptoms of the underlying lung disease can also be found, as in the case of secondary spontaneous pneumothorax. In small pneumothorax, the findings on examination may be normal. However, there could be tachycardia, tachypnea. In large pneumothorax, findings include decreased chest wall movement and expansion, decreased tactile fremitus, hyperresonance on percussion, diminished or absent breath sound. It is important to state that you should watch out for subcutaneous emphysema, especially in traumatic cases. For tension pneumothorax, look for severe breathlessness and rapid deterioration of symptoms, hypotension, tachycardia, cyanosis, tracheal deviation to the contralateral side, and distended neck vein. This is a true emergency, so you need to act fast. Diagnosis and evaluation. In tension pneumothorax, diagnosis is typically clinical. Do not wait for imaging before intervention. Look for respiratory distress, hypotension, absent breath sound, tracheal deviation to the contralateral side. Now we'll look at imaging tools for the evaluation of pneumothorax. The first we are going to consider is the chest radiograph. For chest radiograph, look out for visible pleural edge, which is separated from the chest wall. Look for absence lung markings peripheral to the collapsed lung. Look for hyperlucency of the lung field. contralateral mediastinal shift as in cases of tension pneumothorax, depressed hemidiaphragm, and the deep sulcus sign in supine fins. The X-ray may also show underlying lung disease. These are chest radiographs in cases of pneumothorax. In the first image, we can see the visible pleural edge. We can see hyperlucency of the lung fields in which there are absent lung markings peripheral to the collapsed lung. In this other one, this is perfect for a tension pneumothorax. These are the hyperlucent field with absent lung markings. Or however, if you take a closer look, you see the trachea and the mediastinal structure, they are shifting to the contralateral side. This is the collapsed lung, and this is the depressed hemidiaphragm. The point of care ultrasound scan is useful in emergencies and in bedside settings. It is fast and accurate, and findings include absence of lung sliding, what referred to as the barcode sign or the stratosphere sign, the lung points, which is diagnostic, and the absence B lines, which also supports pneumothorax. The CT scan of the chest is useful in cases of diagnostic uncertainty or in complex cases. It is said to be the gold standard in complex or occult cases of pneumothorax. It helps to confirm small pneumothoraces, identifying underlying causes of pneumothorax like bullae, Bleb's malignancy. It also guides procedures like thoracocentesis. Other helpful investigations include the arterial blood gases, which may show hypoxia or respiratory alkalosis. The ECG is also important. It helps to rule out cardiac causes of chest pain. Management of pneumothorax. Management depends on the type of pneumothorax. Is it primary, spontaneous, or secondary spontaneous, or traumatic? Depends on the size of the pneumothorax, small or large, and the presence of symptoms. Size is estimated from the lung edge to the chest wall at the level of the hilum. Small pneumothorax are usually less than 2 centimeters or less than 15% of the hemithorax. Large pneumothorax greater or equal to 2 centimeters or greater than 15% of the hemithorax. On a general note, start with ABC stabilization, the airway, breathing, the circulation. Give oxygen. Oxygen is very important because it speeds up the reabsorption of air. Let us look at the specifics. First, primary spontaneous pneumothorax. For small pneumothorax, less than 2 centimeters, or asymptomatic cases, observe the patient. This may be sufficient. Supplemental oxygen can also be given. For large and symptomatic primary spontaneous pneumothorax greater than 2 centimeters, options include the percutaneous needle aspiration or a chest tube drainage can be done for the patient. For secondary spontaneous pneumothorax, active intervention is important regardless of the size of the pneumothorax. First step is chest tube drainage. If pneumothorax is unresolved with the chest tube drainage, or there is persistent air leak for greater than 4 days, you have to consider video-assisted thoracoscopic surgery. For tension pneumothorax, which is a life-threatening medical emergency, perform immediately a needle decompression by inserting a 14 to 16 gauge needle at the second intercostal space mid-clavicular line. You will hear a rush of air exiting the pleural space. This is diagnostic of pneumothorax. Follow this with a chest tube drainage. If unsuccessful, consider video-assisted thoracoscopic surgery. This is a summary of management options in pneumothorax. For the primary spontaneous pneumothorax. For the small pneumothorax, observation and high flow oxygen can be given. For the large or symptomatic primary spontaneous pneumothorax, needle aspiration, chest tube drainage. For the secondary spontaneous pneumothorax, chest tube drainage because they usually have 4 reserve. For the traumatic pneumothorax, chest tube drainage and treat associated injuries. For iatrogenic traumatic pneumothorax, it often resolves. Monitor the patient, or you may pass a chest tube if need be. For tension pneumothorax, immediate needle decompression at the second intercostal space mid-clavicular line. This is followed by a chest tube drainage. Details of the procedures. For needle decompression, insert the 14 to 16 gauge needle or cannula at the second intercostal space mid-clavicular line. For chest tube insertion, insert at the 4th to 6th intercostal space, anterior axillary line or the mid-axillary line. Attach it to an underwater seal or a Heimlich valve. Avoid clamping the drain and remove the tube 24 hours after lung re-expansion and cessation of bubbling. Persistent bubbling, especially if greater than 5 to 7 days, you need to consider surgery. If bubbling stops before lung re-expansion, suspect tube blockage, kinking of the tube, or dislodgement. Always check the tube position and patency. Surgical management options. What are the indications of surgery? 1. Recurrent primary spontaneous pneumothorax. Persistent air leak, bilateral pneumothoraces, and when there is failed conservative management. Surgical options include the video-assisted thoracoscopic surgery, which is minimally invasive. A bulectomy can be done, and pleurodesis can be done via the video-assisted thoracoscopic surgery. For pleurodesis, options include thorectomy and pleural abrasion. Chemical pleurodesis can also be done, whereby tack or doxycycline they are instilled into the pleural space to cause fibrosis and inflammation. Open thoracotomy is actually reserved for complex cases or for those who have failed video-assisted thoracoscopic surgery. Recurrent pneumothorax. Recurrence occurs in 30% after the first episode of pneumothorax and 50% after the second episode. Most recurrences occur within 2 years of the initial event. Management of recurrent pneumothorax include chemical pleurodesis and surgical pleurectomy or bulectomy via the video-assisted thoracoscopic surgery. What are the indications for surgical pleurodesis? First, second ipsilateral episode of pneumothorax. 2. First secondary spontaneous pneumothorax in those with low respiratory reserve. 3. The first contralateral episode of pneumothorax. 4. Persistent air leak. And 5. Bilateral pneumothoraces. Potential complications of pneumothorax include re-expansion pulmonary edema, empyema, subcutaneous emphysema, mediastinal emphysema, persistent air leaks, bronchopleural fistula, and recurrence, which is about 20 to 30% after the first episode of pneumothorax. To prevent recurrence, stop smoking, avoid flying or diving for 6 weeks post-event. Consider surgical pleurodesis in recurrent cases. To recap, pneumothorax is air in the pleural space, often causing lung collapse. Could be classified in terms of etiology and airflow. Tension pneumothorax is a clinical emergency. Diagnosis can be clinical. Chest X-ray and point-of-care ultrasound scan are vital tools. Management depends on type and severity of the pneumothorax and can range from observation to chest tube or even surgery. Recurrence is common. Preventive strategies are important. Prevent recurrence through smoking cessation and fluorodesis. Thank you for watching, and I hope you've learned something important in this lecture. If you found this video helpful, please like, share, and subscribe to ClinMed Compacts. Drop your questions or feedback in the comments, and don't forget to hit the notification bell for future updates. This is ClinMed Compass, your path to medical excellence.